we'll discuss about the acute respiratory distress syndrome, and it is a life-threatening syndrome, and it is due to respiratory insufficiency. To simply see about the acute respiratory distress syndrome, it is due to acute lung injury, which causes the inflammation of the endothelium and also cause alveolar epithelial cell damage, and which increases the vascular permeability. So it causes edema formation in the alveolar space, and it causes the epithelial cell death. So next, acute respiratory distress syndrome is of two types, that is neonatal and adult ARDS. So clinical features are: in neonatal ARDS, soon after the birth there is dyspnea, trachypnea and hypoxia. Due to hypoxia there is cyanosis, and in severe cases it can lead to death. In adult ARDS there is diffuse alveolar damage, which causes the acute lung injury. So after the acute lung injury there is sudden cyanosis, and there is trachypnea, tachycardia, and there is hypoxemia. So etiology: in preterm infants we can see neonatal ARDS, whereas in adult ARDS we see there is mainly two causes, that is direct lung injury or indirect lung injury. In direct lung injury we have pulmonary infections and oxygen toxicity when we inhale toxic gases, aspiration of gastric contents, and also during the drowning. So in indirect lung injury we have shock, embolism, pancreatitis, and other radiations and many other causes. So pathogenesis, we have different steps. We'll go one by one. First step is to activate the endothelium. So what happens is all the etiological causes, any of them can cause pneumocyte injury. So the pneumocytes are injured, so it is sensed by alveolar macrophages in the alveoli. So what happens, it will release tumor necrotic factor and also interleukin 1 or any other cytokines, interleukins, which will cause endothelial injury, and also can activate the endothelial cells to express the adhesion molecules for neutrophils or other leukocytes. So when you see here, you can see this is a diagram. For left side there is a normal alveoli, and right side we can see acute lung injury. So we see whenever there is a damage in these pneumocytes, what happens is the alveolar macrophages gets activated. So whenever these alveolar macrophages gets activated, it releases tumor necrotic factor and interleukin 1. So what happens is these cause endothelial damage, and also it increases the adhesion molecules that are present in the endothelium. So what happens is finally some of the endothelium are injured and swollen and show adhesion molecules for neutrophils. So what happens is the neutrophils get adhered. So the next step is adhesion and extravasation of neutrophils. So when you see, the activated endothelial cells express the adhesion molecules, so the neutrophils adhere to the activated endothelium and migrate into the alveoli. So after getting into the alveoli, they release three things, that is proteases, reactive oxygen species, and cytokines. So what is this proteases do? These proteases degrade the proteins inside the alveoli, and reactive oxygen species cause the epithelial cells of the pneumocytes damage, that is pneumocytes, and the cytokines releases. There is increased recruitment of the leukocytes, and it causes the increased endothelial injury. So these cycles go on, and so there is more and more recruitment of the leukocytes, and more endothelial injury. So you can see in this now. So what happens is adhesion molecules are increased, so these neutrophils get sequestered and migrated into the alveoli. So after the migration into the alveoli, they are again activated by these tumor necrotic factor interleukin 1, which causes release of its contents like platelet activating factor, leukotrienes, and proteases, which cause more destruction, and also it increases the endothelial injury. So the next step is we saw up to endothelial injury. So after endothelial injury we have next is accumulation of intraalveolar fluid. How it happens, we'll see. After endothelial injury, we have pulmonary capillaries becomes leaky, because continuous injury these cells become leaky to the contents of the capillary. So pulmonary capillaries become leaky, allow intraalveolar edema fluid formation, that is which is protein rich. So protein rich edema plus debris of the dead alveolar epithelium forms the hyaline membrane. When you see here, so due to injury to the endothelium, it causes the pulmonary capillaries to become leaky. So it allows the intraalveolar edema fluid formation. So edema fluid will go into the alveoli, and which is protein rich. So this protein rich alveolar fluid along with the damaged cellular debris of the endothelial cell will cause then hyaline membrane on the surface. So it is also called as hyaline membrane disease, the respiratory distress syndrome. Okay. So, and also there is a type 2 pneumocyte injury damage. So there is decreased surfactant, so gaseous exchange decreases. Next, coming to resolution of the disease. So after some time there is decreased inflammation. So macrophages will remove the debris, and it releases tumor, TGF beta, that is transforming growth factor beta, and platelet derived growth factor. So it increases the fibroblast and collagen deposition in the cell, and fibrosis of the alveolar walls occur. You can see the fibrin gets deposited on the walls, and it removes the hyaline membrane, and it causes fibrosis. Next, bronchial stem cells will replace the type 2 pneumocytes, and uninjured capillaries will grow and restore the endothelium. That is the resolution. Next, coming to the morphology, grossly we can see heavy, firm, red and boggy lungs, and histology we can see alveolar edema and damage to the walls, and hyaline membrane we can observe. You can see here, and this is the diffuse alveolar damage in acute respiratory distress syndrome. You can see these are the hyaline membranes which are showed by the arrow. Okay, you can see these are the infiltrates of the macrophages and the neutrophils. Okay.